Mervyn Singer, who's going to provide us with an update on the role of CPAP in managing patients with COVID-19.
Good evening. My name is Mervyn Singer. I'm Professor of Intensive Care Medicine at University College London, and I'd like to spend the next 10 minutes talking to you about CPAP and COVID-19. CPAP has been around 100 odd years, and to my knowledge, the first description in heart failure was by Dr. Poulton in 1936. He used the Pulmonary plus pressure machine that used a Hoover or an Electrolux vacuum cleaner to generate the positive pressure, and the patient wore a mask with a valve that kept the lungs splintered open and stopped them returning at the end of expiration to near atmospheric pressure. Apart from describing cases of heart failure being successfully treated with CPAP, he also showed the same for patients with asthma. But what about CPAP and COVID? First, let's quickly describe what's currently understood about the pulmonary pathophysiology. There's this nice short paper by Luciano Gattinoni and colleagues in the Blue Journal who describes a dissociation between a relatively normal lung compliance yet severe hypoxemia. And he found in 16 patients that these patients had a huge shunt fraction, up to 50% or even higher. And this is very rarely seen in traditional ARDS, this contrast between normal compliant lungs yet severe hypoxemia. And he explained this by a loss of regulation of perfusion within the lung and loss of hypoxic vasoconstriction. So he suggested there was this, as he put it, a remarkable hyperperfusion of gasless tissue. And he felt the benefit from CPAP, high PEEP, or prone positioning came not from the recruitment of collapsed alveoli, as is traditionally seen with ARDS, but rather from redistribution of perfusion within the lung. However, there was fear and dread about the use of non-invasive support because of the risk of healthcare worker infection. So when the outbreak happened in China at the end of January, they found many patients who were hospitalized needed more than face mask oxygen, and their early strategy of early intubation and mechanical ventilation meant that their intensive care resources were quickly overwhelmed. I wrote at the beginning of March, when it was becoming apparent that COVID might be coming to our shores, and asked him several questions, and he recognized that there was a widespread use of non-invasive support. CPAP, high-flow nasal oxygen, and so forth. Yes, there may be a high failure rate, and delayed intubation may not be a good idea. I'll talk about that shortly. However, he pointed out that with hundreds of patients presenting with severe hypoxemia that often didn't respond satisfactorily to oxygen, there simply wasn't the resource for invasively ventilating everybody. I asked him some other questions, and he wrote back a few days later. We'd been advised in the UK to think about ventilating patients if they needed more than 4 litres a minute of oxygen because of the risk of healthcare worker infection. I felt it was a bit excessive, and he did too. So he felt it was well worthwhile doing a trial of non-invasive ventilation, and depending on the patient's response, if they remained hypoxemic and or working very hard at their breathing, these are the patients who should be considered for early intubation. So there are these two opposing facts. There's two acronyms for you, SILI and VILI. SILI is self-inflicted lung injury. So patients spontaneously breathing, taking very large breaths, will generate very high transpulmonary pressures that may potentially result in lung injury. On the other hand, there's VILI, ventilator-induced lung injury. So we know it's been well recognised that patients going on to mechanical ventilation, unless you're very careful, that in itself can induce barotrauma, volutrauma, shear stress trauma, and complications thereof. However, the Italians, when it broke out there in early March, didn't take on board the lessons from China. They intubated and mechanically ventilated lots of people early on, and their resources were overwhelmed. A colleague of mine, Paolo Pelosi, who's a professor in Genoa, sent me lots of guidelines, and this is from the region of Liguria in which he works, and you can see CPAP featured strongly in their guideline. And another friend who was one of the leaders of the Lombardy Regional Emergency Department Response Team said to me, "I have no data, but I'm absolutely sure CPAP is the answer." I quizzed lots of other Italian colleagues. They were seeing many patients in their hospital. Their ICUs were full to overflowing, and they were using not only in the ICUs but the wards CPAP, high-flow nasal oxygen, and so forth. They weren't seeing problems with oxygen supply in their hospitals, and approximately 40 to 50% of patients could be kept off ventilators with the use of non-invasive ventilation. Importantly, survivors who were being mechanically ventilated needed a couple of weeks, so this scarce resource was being blocked for quite a long period of time. And the final crucial point, they hadn't either heard of or seen directly any healthcare workers looking after these patients ending up as intensive care patients themselves. When COVID hit the UK at the end of March, again, we hadn't taken on board the lessons from China and Italy. We performed early intubation and mechanical ventilation, and that also overwhelmed our resources. So this was reported in The Guardian on the 20th of March, the night before. Northwick Park Hospital had to declare a critical incident because all of their ventilators, intensive care and anaesthetic ventilators, were in use. On the same day, we implemented our strategy at UCH, which embraced the use of CPAP. I won't go through our pathway in any detail, but we looked at an oxygen challenge and the patient's response, and they went into red, amber and yellow pathways, and depending on that response, both in terms of respiratory rate and comfort and oxygenation, they either stayed on oxygen, were trialled on CPAP, but if that failed, went for early intubation or could manage on CPAP alone. And clearly these patients were monitored to look at progress. At the same time, we resolved to increase the CPAP capacity within our hospital outside the ICU. And there was this great exercise run by our respiratory physicians. There was a big training program for doctors and nurses, and clearly we had to get more devices as there were only 12 in the trust. This is our latest pathway. There's an app that's available for free on Apple Store, and essentially we're still using the red, amber, yellow pathways, although it's a bit simplified. And to generate more devices, we had great fun working with our engineers at University College London and the Mercedes F1 team to reverse engineer a 30-year-old CPAP device, a simple mechanical device, and within a few weeks they'd made up to 10,000 of these devices that got regulatory approval and have gone around the country. By the 28th of March, it was recognised that perhaps the fear about CPAP was exaggerated, and there did seem to be an important place for CPAP in preventing many patients needing invasive ventilation. Did it work? Well, this is the preliminary UCLH data. About a third of our patients came intubated to the unit, and this includes many patients we took from other hospitals, of whom about half have died, half have either been discharged or are still patients in the ICU. Of the 2/3 managed initially on predominantly CPAP, half required subsequent intubation, of whom a third have died, and half have remained not intubated, a quarter of whom died where CPAP was a ceiling of care, and 73% have been discharged. Likewise, on the ward, about 60% were for full escalation, and 3/4 of these remained off CPAP. 40-odd% had CPAP as a ceiling of care, and 30% of whom survived. In terms of healthcare worker infection, we, like China, Italy, France, Spain, haven't seen any severe infection in healthcare workers looking after these patients, though yes, they're cohorted into specific areas and PPE has been worn. We did some environmental screening on our CPAP ward and there was no airborne virus, and that reinforces messages in editorials that we've written. This came out in anesthesiology. And the other thing to note, even patients on a face mask can generate transmission of viral particles up to 8 meters. The other fear about too much oxygen being used and depleting the hospital stores, again, didn't seem to be borne out. So yes, you have to manage your oxygen supply, but it did seem to work. In summary, therefore, CPAP allowed about half of our patients to avoid being ventilated. Clearly, you've got to identify early on patients who are failing CPAP, work of breathing, respiratory rate, hypoxemia, and these patients likely would benefit from early intubation. Does it make a difference? We don't have outcome data, we don't know optimal timing, but it certainly did spare our ICU and ventilator resource, and it's certainly been useful for patients where CPAP has been a ceiling of care for those who weren't appropriate to be ventilated. On that note, thank you very much for listening.